I'm going to start today, as Catherine said, talking about the AAMC's workforce projections, and then also spending some time talking about the physician pipeline, what we're expecting to happen in the coming years in terms of growth of our physician workforce. And then I'm going to turn in the latter half to talking about healthcare transformation, all the activity underway to transform care and implement new payment models and care delivery models, and talk through some of what that might mean for our future workforce needs. This first slide shows the AAMC's projected shortages. Some of you may have seen this before. We're fairly famously on record for stating there's going to be a shortage of physicians of up to 91,500 by 2020. And what's on display here is the bottom line shows our expected shortages without the implementation of the Affordable Care Act, and then the orange line on top shows the additional expected shortages that will occur as a result of the newly insured coming into the mix. And this is based on a continuation of healthcare utilization plans and practices that were in effect at the time we put these projections together, so it doesn't account for all of the new care transformation that's underway. And it's important to note that half of the expected shortages are in primary care and the other half are expected in specialty areas. So, and it's based on current utilization and practice patterns, and it's largely driven by growth and aging of our patient population, as well as the aging of our physician workforce. So one of the solutions that's discussed quite a bit is increasing our physician workforce, and in 2006 the AAMC called for a 30% increase in medical school enrollment, anticipating that we were going to see increased demand. And the blue area at the bottom of this graph shows the number of new entrants into allopathic medical schools. And we're projecting that by 2016 we'll have over 4,000 new MDs in place. That will be pretty close to our 30% increase in medical school enrollment. And then it's not just allopathic medical schools that are increasing, osteopathic ones are as well. And we expect them to double during that same interval, and increase by another a little over 3,000 new DOs will be entering medical school by then. But it's not just MDs and DOs that are growing. We're also expecting growth in nurse practitioners and physician assistants. Since the beginning of the decade, since 2001, the number of NP graduates, nurse practitioner graduates, has increased 69%, and the number of PA graduates has increased 41%. So we're seeing a lot of growth in our healthcare workforce. But from the physician perspective, the real rate limiting factor is number of residency positions available. And this graph shows the number of entry-level residency positions that have been in place over the past decade. And despite the Balanced Budget Act cap in the late 90s, we have seen a growth in entry-level positions of a little under 1% per year. But we've seen a faster rate of growth in MD and DO enrollment of closer to 2% per year. So it's really the residency pipeline that will be the ultimate predictor of our future workforce growth. And we're currently at the rate, when you combine in AOA accredited residency positions, which are not on display here, at the number of entry-level positions that we built into our projections that I showed earlier. One of the focuses of this conversation, and something that's on everyone's mind, is the supply of our primary care workforce specifically. And during this past decade, we've seen a decline in the number of students, USMDs, that are likely to become primary care physicians. But it appears that maybe it's stabilizing at the moment, with about 25% of students entering residency training in 2010 estimated to become primary care physicians. And this is growth in, I think this is an important thing to keep our eye on, and it could partly be attributed to the increased attention and focus on primary care that's come about in conjunction with the Affordable Care Act, and the new payment models that are underway that make it increasingly more attractive for U.S. graduates to enter the field. It'll be important to keep an eye on this and see what happens in the future, but there is some indication that it's going up if you look just at entrance into family medicine residency training programs. And this accounts for subspecialization. So we factored in the number who are likely to go on to subspecialize in this estimation. Other AC provisions that are important to keep track of are that there were approximately 700 positions under the Balanced Budget Act that were funded but were not really filled, and so those slots have now been redistributed primarily to primary care residency training positions and general surgery residency training positions. In addition, there was funding to establish teaching health centers, and that will contribute an additional 500 primary care residency positions over the next 10 years. And then it's also important to keep in mind an avenue for encouraging primary care, which is the National Health Service Corps, where physicians have loans repaid in order to practice in underserved areas. And now there are approximately 10,000 providers in the field today practicing in urban, rural, and frontier areas. And there's also increased flexibility in participation in the program. And there's with a half-time option where you can either work part-time and double the amount of time that you're in the National Health Service Corps, or have a 50% reduction in your payment amount, which might make the National Health Service Corps program more attractive to students. So now I'm going to turn towards transforming care delivery and all the activity underway. And this next slide shows just a host of the activities underway that are really going to shape our future workforce needs if they continue to take hold and expand. And the size of the gears on this don't convey any kind of relative role, but they're just to show all the different activities underway. And one of my colleagues likes to joke that it looks like the gears are grinding to a halt, and I hope not. That's not intentional. It's just the function of how the slide was put together. But it goes from accountable care organizations to increased focus on team-based care, the Choosing Wisely campaign, which is an effort to really make sure that only the necessary services are provided, increased focus on care coordination and medical homes, efforts to look at and revise scope of practice laws, bundled payments, hotspotting efforts to really target resources to super utilizers of care and improve the care coordination for that population, new telehealth programs that offer access to rural and underserved populations in new ways, increased patient engagement, employer-based care, which makes it easier for patients and improves care coordination. All these activities are happening now and will dramatically change our workforce needs and are really centered on achieving the triple aim that Don Berwick has famously outlined through the IHI of improving the patient experience of care, that includes both quality of care and patient satisfaction, improving population health, and then doing those two things above while also reducing cost of care. And they are supported by new payment models. Under traditional payment models, it was really primarily fee-for-service, and bad care paid the same or even better if you got readmitted, or care coordination was not reimbursed or reimbursed adequately. And that's an important component of all the new care delivery models that are underway. And hospitalizations paid, readmissions meant even more money, procedures paid more than cognitive visits, and there was really very little incentive to control costs. New payment models are really attempting to turn all of that on their head, and two that are gaining increased traction are fixed fees or shared savings models. And they're all targeted towards improving achieving the triple aim, where you could either, with a fixed fee model, get a set amount of money per patient on the front end, have this clean slate to come up with a new way of delivering care that will lead to reduced unnecessary care and duplications of testing and avoidable admissions and readmissions, all while simultaneously improving population health, quality of care, prevention, and coordination and outreach. Or it can be flipped, so if you agree to do all these, if you are able to demonstrate reductions in all these in unnecessary care and admissions, et cetera, and improve population health, then you can get a portion of the shared savings that result. And this really is a new approach to care that involves a lot of care coordination and team involvement. And some of the early practitioners of this model, such as Group Health in Seattle, actually were presenting once on their model and got to the slide where they were showing what impact this had on their patient panel size, and I couldn't wait to see how many more patients they were seeing as a result of integrating nurse practitioners and physicians and assistants and other team members into care delivery. And they actually reduced their patient panel size from 2,300 to 1,700 as a result of these efforts, and increased their appointment length from 15 minutes to 30 minutes, which is not what I was expecting. But that was their recognition of the need for more care coordination and outreach and prevention focus, and all the things that under previous payment models weren't as adequately incentivized. So it'll be really important to understand as these new payment models and care delivery approaches take hold, what this will mean for our physician needs in the future, even when you bring on other team members. A lot of these efforts are sponsored at the federal level with the Center for Medicaid and Medicare Innovation, and this is a map from their website that shows all of the transformation across the nation that they are currently piloting all these innovation awards and challenges and accountable care organizations and a whole host of activities. And the orange squares represent statewide efforts, and the blue circles, which seem to be engulfing the eastern half of the continent, are local efforts and activities. And they are just, it's unclear exactly how many of these will take hold and which ones will be the most effective, and so there's just a tremendous amount of activity underway. So this is a really exciting time, and this is just what's happening at the federal level, but then also states are increasingly engaged in moving towards linking patient-centered medical homes with their Medicaid reimbursement models. And currently 23 states do so, an additional 14 have plans in the works to link PCMH, patient-centered medical home models, with their Medicaid payments. And this graph shows NCQA certification adoption rates across the state. And on approximately 7% of primary care physicians today have NCQA certification. And it ranges in the state from 0, I think that's in Oklahoma, all the way up to 37%, I believe that's in Maine. But it's probably an underrepresentation of the total amount of patient-centered medical home adoption rate, because in the state of Oklahoma and Minnesota, for example, those are two states where they have their own state recognition programs. So it looks like they don't have any activity in that way underway in their states, but there's actually quite a lot going on. And it's not just the state payers that are changing, it's also private insurance companies. I think we'll be hearing a little bit more about that later from our speakers from Blue Cross, Blue Shield, and WellPoint. But there's just, everyone really seems to be looking to see how we can transform care to achieve the triple aim in new ways. And as a result, a new and expanded workforce is emerging. This draws from the CMMI Innovation Challenge Awards applications that were announced about a year ago. And it shows how, and it talks about the different care team members that are going to be integrated in new ways in support of their efforts to transform care for their populations. And I've divided this into two columns. On the right-hand side are positions that are fairly ubiquitous in medicine: medical assistants, dental hygienists, behavioral health, social workers, et cetera. But now they're going to be linked and integrated in care in new ways, or take on new responsibilities, where medical assistants might take on more of care coordination or scribing activities, just as two examples. And then on the left are some new roles that are emerging in support of helping patients and improving care coordination. Those are patient navigators that help patients figure out the healthcare system and how to best approach it. Nurse case managers who have been around but maybe are funded to greater levels now. Care coordinators and community health workers really are a growing workforce that can be easily trained and integrated and can really have a dramatic impact on patient health and outcomes and cost of care. And then care transition specialists, living skills specialists, patient and family activators, Grand Aids, which is a program to bring back healthcare professionals into healthcare delivery as more health coaches and patient navigators after they've retired. Peer and family mentors. There's just a whole host of activity underway and new professionals that are being integrated into the care delivery that could transform our health workforce needs. But as I mentioned earlier, some of the places that are starting to use these professionals in new ways and volunteers are not necessarily able to increase their patient panel size because they're taking on activities and roles that maybe haven't been done as adequately as they needed to under old payment models. So this leads to our, me to come back to the slide I originally presented, which is, if you recall, I said that it was based on old care delivery models and systems of care, and there's so much innovation underway that will continue to take hold that really leads to question, what are our future workforce needs going to be? Are we going to need even more primary care physicians to support this level of healthcare transformation? Or what impact is this going to have on demand for specialists if we are effective at reducing unnecessary emergency room visits and hospitalizations and reducing readmissions? Will we need fewer specialists? There's so many question marks out there about how this will all play out. And we have a lot of, and this is an area that is really leading many in health workforce to investigate in greater depth, but we don't have a lot of the data right now to really answer these questions. But we look forward to opportunities to really delve into this in greater depth. So overall, we're facing significant physician shortages in the future with the newly addition of the newly insured into the mix, as well as the growth of our aging of our population and the aging of our physician workforce. And while there's a lot of effort underway to increase undergraduate medical education, and it really is the graduate medical education pipeline that can be the rate limiting factor of how much we'll be able to increase our overall workforce. But either way, we'll still need to have healthcare transformation underway to ensure access to care. And new care delivery models hold potential for offsetting demand, but the workforce implications really need to be better understood and monitored as we move into the future.